We are live now, sir.
Good evening, all. A warm welcome to ExRxIndia's for the students, by the students, in association with Pikes Studio, Research Creation, Sairam Academy. Today's students' first topic is benign paroxysmal positional vertigo, BPPV, will be presented by Ms. Rinita Mascarenhas from St. John's Medical College, BPT fourth year student. I welcome ExRx India team members, Dr. Rupesh and Professor Duna Saha. Now I welcome Ms. Rinita to present her topic. Ms. Rinita.
Good evening, sir, and thank you for the introduction. My topic for today is benign paroxysmal positional vertigo. Just 1 minute. Before beginning the topic, I would like to thank ExRx India team for this wonderful opportunity and the Department of St. John's and the Department of Physiotherapy at St. John's Medical College for their constant support and guidance. Moving on, my topic for the day is benign paroxysmal positional vertigo, commonly known as BPPV. It is the most commonly occurred vertigo in adults. So, as the term speaks for itself, BPPV, B stands for benign, which is a condition that is not progressive over a period of time. So, therefore, it is not it's not looked as a complication. Paroxysmal reflects that the spell is of episodic rather than persistent. That means when the symptoms are elicited, it is short-lived and of sudden onset. While the other P stands for positional, which implies that here it implies that the symptoms are elicited when the patient is in a particular position or when there is a change in position, while V stands for a false disoriented sense, a rotational sense of movement. Some patients wrongly term it as being dizzy or lightheaded, but this is wrong and it should be termed as a false sense of disorientation. Now, before we understand what BPPV is, we need to look into the mechanism of how BPPV occurs and what is the normal functioning. For that, we'll go into looking at the structural aspect. Now, the system responsible here is the peripheral vestibular system. The peripheral vestibular system is located in the inner ear in a membranous labyrinth called the vestibular labyrinth. Now, each labyrinth consists of five neural structures. That is the three semicircular canals and two otolith organs. The three semicircular canals are responsible for movement in an angular movement, and the two otolith organs, that is the utricles and the saccules, are responsible for linear acceleration. Now, speaking about the utricles and the utricles and the saccules are formed of a special sensing organ called the macula. As you can see, the enlarged version near the semicircular canal. They consist of hair structures known as stereocilium and kinocilium. The smaller hair structures are called stereocilia and the larger ones are called kinocilium, and these are embedded in a gelatinous membrane called the otolithic membrane. And on top of them, you can see small calcium crystalline structures known as otoconia. These otoconias are highly gravity effective. Now, the difference between the utricle and the saccule is that the utricle is less responsible for sensing motion in a horizontal plane, that is, in a linear horizontal plane. As you can see, the most simplified manner here in the down picture, it signifies the orientation of the utricle. It's in an horizontal manner, while the saccules are placed vertically. They sense vertical linear acceleration. The same structure of the macula is placed horizontally in utricle and vertically in saccule. Now, stating an example for horizontal linear acceleration and vertical linear acceleration. When there is a horizontal linear acceleration, the utricle is stimulated. Now, stating an example for that is when you're driving in a car and a dog comes over suddenly, you hit the brakes. When you hit the brakes, what happens? Our body moves forward. When our body moves forward, our head also moves forward. This causes the gravity is moving also in a forward direction. This causes the otoconia which is present to move forward because they are highly gravity effective. When the otoconia moves forward, it drags the otolithic membrane along with them, causing the stereocilia to beat towards the kinocilium, hence opening of sodium and potassium channels causing depolarization of the cell. When there is depolarization of the cell, there is release of neurotransmitters, and this release of neurotransmitter causes an action potential to be generated to the vestibular nucleus. Now what happens in, I hope this part is clear, and when we, instead of pressing the brake, we press the accelerator. When we press the accelerator, our head moves backwards. When our head moves backward along with the body, the gravity is acting again backwards, pulling the otoconia along with it. Let's consider this to be the stereocilium and the kinocilium. And when the, this is the stereocilia, this is the kinocilia. So when the otoconia moves this way, the stereocilia will be towards the kinocilium. But when it moves backwards, as in when we apply acceleration, it beats away, causing the closure of sodium and potassium channel, and hence there won't be release of action potential and a release of neurotransmitters, and therefore there won't be any action potential generated to the vestibular nucleus. Now coming to the function of the saccules. Now saccules, as I mentioned, is responsible for movement in a vertical linear acceleration. So stating an example for that would be going in an elevator, and as we are moving up, what happens? The gravity is acting downwards. This causes the otoconia to move again downwards, causing the stereocilia to be towards the kinocilium, and hence there will be opening of sodium and potassium channels, there will be release of neurotransmitters, and there will be an action potential generated to the vestibular nucleus. But what happens in case the lift stops, instead of going up, it starts going down? When it goes down, there is a drag force acting against our body. This causes the otoconia to move in an upward direction. When the otoconia moves in an upward direction, it drags the otolithic membrane also with it to move in an upward direction, causing the stereocilia to beat away from this kinocilium. Hence, there won't be opening of sodium channels nor potassium channels. Therefore, there will be hyperpolarization of the cell, causing therefore there won't be any release of neurotransmitters, and therefore there won't be an action potential generated to the vestibular nucleus. Hoping that you all have understood this, we'll go on to the function of the semicircular canals. Now, the semicircular canals are responsible for movement in an angular movement. So, what do they do? An example for that would be, if I turn to my left, my horizontal semicircular canal is being stimulated. If I look up, my anterior or my superior semicircular canal is being stimulated. When I look down, my when I move my head to the sideways this way, my posterior semicircular canal is being stimulated. So now the enlargement that you can see at the most end part of the semicircular canal is called as the crystallis ampulla. Now this crystallis ampulla is made up of a gelatinous membrane called cupula, and as you can see, hair structures pointing upwards towards it is again known as stereocilium and kinocilium, and the end of it is are the nerve fibers which are connected to it. Now, to understand better the function of the semicircular canal, when I turn to the left, my left horizontal semicircular canal should be stimulated, while my right horizontal semicircular canal should be inhibited. So, to understand this mechanism, when I turn to my left, the semicircular canals are also moving with it, but the endolymph does not flow with it. The endolymph is slightly thicker than water, so therefore due to inertia it flows in the opposite direction of the semicircular canal. So if I'm turning to the left, the endolymph will flow towards the right. That causes the deflection of the cupula when I finish my movement. So it flows into the crystallis ampulla, causing the deflection of the semicircular canal. That deflection of the cupula causes the stereocilia to be towards the kinocilium, and hence there is opening of sodium and potassium channels, causing an action potential to be generated within the hair cells. This hair cells then release neurotransmitters, causing an action potential to be generated to the vestibular nucleus. Now what happens in the right ear? In the right ear, the fluid moves away from the crystallis ampulla, causing no deflection of the cupula. Hence, there won't be any action potential generated to the vestibular nucleus. Now, I think I've mentioned vestibular nucleus quite a lot of times. The function of vestibular nucleus is, now when I turn to my left horizontal semicircular canal is stimulated. This causes impulses to reach to my medial vestibular nuclei. When the impulses reach to my medial vestibular nuclei, there is a stimulation of the contralateral abducent nuclei and the ipsilateral oculomotor nuclei. This causes the ipsilateral medial rectus, in our case the left medial rectus, and the contralateral lateral rectus, that is the right lateral rectus, to be stimulated. If you want to see this, please go and stand in front of the mirror, and when we turn to the left, you'll see that our eyes maintain focus. This is also known as the vestibular ocular reflex. Now, because we have to turn to the left when someone is calling us or anything, there is a cerebral pathway which inhibits this mechanism and causes the stimulation of the left lateral rectus and the right medial rectus. This causes us to look in the direction of the movement. Okay, so this is the normal functioning of the vestibular system, of the peripheral vestibular system. Now what happens when in BPPV? Now BPPV is believed to occur in two mechanisms known as cupulolithiasis and canal lithiasis. Both these mechanisms involve the dislodging of the otoconia. So in cupulolithiasis, the otoconia which is dislodged is being adhered into the cupula of the semicircular canal. So therefore, when the endolymph flows through the ampulla, there is excessive deflection of the cupula due to the presence of this otoconia. That causes a sense of rotational disorientation for the patient, and hence they term it as feeling dizzy or feeling lightheaded. But in canal lithiasis, the otoconia is free flowing. That is, it moves along with the endolymph throughout the canal, causing, and when that particular canal is stimulated when being turned, there is deflection of that cupula of that semicircular canal. Hence, the patient feels the rotational sense of movement. Now, what are the common symptoms a patient may face? They may face a brief episodic vertigo lasting for 30 seconds to 1 minute. It is 30 seconds to 1 minute because when the cupula deflects in a normal person, it takes 20 seconds for them to around 20 seconds for it to straighten itself because of the backward pressure. But in a person with BPPV, due to the presence of otoconia, this wait takes a little more takes a longer time when compared to a normal person. Hence, it is brief and it has to be episodic. The next symptom that we observe is change in the position of the head. So these symptoms are elicited when there is a change in the position of the head. This happens because of this otoconia deflecting the cupula, and hence only when that particular canal is being stimulated, only at that point will the cupula generate action potentials, and hence there will be a symptom that is elicited. Nystagmus occurs because of the vestibular inhibition and stimulation pathway that I mentioned previously, that causes an involuntary eye movement. So there are two types of nystagmus occurs here. It could be geotrophic or apogeotrophic. Geotrophic is beating towards the ground, while apogeotrophic is beating away from the ground. Nausea occurs only in severe cases but not with everyone. Coming to examination, the patient should describe the above mentioned clinical features. It should be, that is, the symptoms that are elicited should be brief and should be of sudden onset and should be based on the positional. Occupation history is necessary because it is shown that those who work with heavy machineries have a history of acute vertigo. Possible secondary causes could be conditions like traumatic brain injury, recent otological or non-otological surgeries. Other comorbidities could be blood pressure, should be assessed of the patient because we could rule out other conditions like orthostatic hypotension. Areas to be assessed include strength of the muscle, to ensure that it's just BPPV. Please note that in BPPV there is no symptoms of there won't be any strength deficit because we saw it is only the otoconia causing the deflection, and hence there is action potential to be generated. There can't be a possibility of strength being involved. If there is strength involved, the other pathologies should be looked at. Balance and coordination also will not be impaired in a BPPV positive patient. Blood pressure to assess if the patient is orthostatic hypotension, if he has it or not. Coming to vestibular benefit Rehabilitation Benefit Questionnaire. This questionnaire was designed to assess if the patient pre and post the effect of vestibular physical therapy in a patient. So it's a 22 based questionnaire. There are two parts to these questions. The first part consists of symptoms related to anxiety, motion related vertigo, and the second part consists of the impact of these symptoms on the quality of life of the individual. So along with these questions, there is an answering template for the therapist, which he has to mark based on the patient's description of the based on the patient's description for the answer. So he has to score accordingly. Then once he finishes scoring, the part 1 and part 2 should be summed separately and multiplied into 1.52. And then the part 1 and part 2 is added separately. That is known as the sub score for the two parts. Now to know the percentage of deficit the individual is facing when compared to how he was normal, we multiply that into 0.76. Now the numbers that I mentioned, 1.52 and 0.76, these are constants of vestibular rehabilitation benefit questionnaire and they cannot be changed. Coming to motion sensitivity quotient is based on the intensity and duration of the perceived symptoms that the individual feels. So here the patients are put in 16 standard positions which is prescribed by the motion sensitivity quotient to elicit symptoms, and the therapist grades them based on the patient's explanation. That is, in one position, if they elicit a symptom which is mild and of duration 5 to 10 seconds, then we grade it as, that position is graded as 1 plus 1, 2. So the same way for 16 positions, we add the intensity and duration and then sum it up at the last. Once we sum it up, we multiply it by the number of positions, that is 16 positions, and then divided by 20.48, which is a constant here. And if the score ranges from 0 to 10, the patient is said to have mild dizziness, 11 to 30 moderate dizziness, 30 to 100 severe dizziness. Now coming to the test, the first test is the head impulse test. This is based on the patient's to assess the vestibular ocular reflex. So the patient is either sitting or standing and and the therapist stands in front of the patient. He instructs the patient to concentrate on a point. It's usually the therapist's nose, and then with one swift motion, the patient turns the therapist turns the patient's head in one direction. Now, in a normal person, the patient continues to focus on the point that is fixated on the therapist's nose, while in a patient with a defective labyrinth, the eyes move in the direction of the head. That is, the fixation is lost and then he retracts it back. This is one of the tests to detect if the functioning of the labyrinth. Now, head shaking induced nystagmus test. In this test, it requires the patient to be in sitting position with the neck flexed to 20 to 30 degrees and is instructed to keep their eyes closed. The therapist oscillates the head for 20 to 30 seconds, after which the therapist applies a Frenzel goggle. This goggles are a special type of goggles which has magnifying glasses in them, and they help they help the individual not to fixate on a certain thing, and the therapist can observe the patient's nystagmus based on due to the magnifying glass. Now coming to the vestibular function test, these tests are performed by otolaryngologist and not by physiotherapist usually, and it requires a vestibular function test. Therefore, I won't go into the detail of it, I'll just explain superficially. The first test is known as the electrovideo nystagmography test. This test helps us to detect the cause of dizziness that requires to cause of dizziness. It requires a patient to apply the special type of goggles which has small lens, and also requires a patient to apply surface electrodes on the surface of the near the eye and near the ear to detect the impulses that is being generated. So one of the tests that is performed to assess semicircular canals is putting the patient in various positions to elicit nystagmus. So when this happens, as you can see the graph in the left top corner, the graph will be placed. So this gives the therapist an idea of which canal is being stimulated that causes the symptoms. In rotational chair test, this determines whether dizziness is due to an inner ear or brain or both. It requires a motorized chair and the patient to be sitting in it in an enclosed room, as you can see, with special goggles that detect nystagmus. These are of various subtests as well. So one of the tests which is used to detect BPPV is a visual fixation reflex test. It involves the patient to fixate on a visual target that moves along the rotatory chair. This typically decreases the vestibular gain in a BPPV patient. This whole white room that you can see moves along with the patient. Now the next way, that is the most common way clinicians and therapists detect BPPV, is through the Hall-Pikes-Dix maneuver. In the Hall-Pikes-Dix maneuver, all we require is a couch which is not close to the bed. If it's close to the bed, it is difficult for the therapist to maintain the the position of the patient's head in extension and rotation. Therefore, for some reason, if they are not able to get the couch off the wall, then we can place a pillow at the upper back of the patient so that they can maintain their head in extension and rotation. So in this test, it requires a therapist to be standing on the affected side of the patient. Because I couldn't get a model, I have a helmet with me. As you can see, this is the unaffected side. This is the unaffected side and this is the affected side. So it requires a patient to be in long sitting, and then the therapist is standing towards the side that has to be treated, that has to be examined. He places the head on the patient's face, rotates it 45 degrees, extend it 30 degrees, and in one swift motion, he brings the patient downwards, maintaining the extension as well as the rotation. This elicits symptoms. If it's an anterior semicircular canal BPPV, the patient will have a geotropic type of nystagmus, and if it's a posterior semicircular canal BPPV, the patient will have a apogeotropic type of nystagmus. Now, if no nystagmus is elicited, but if the patient still complains of BPPV, then we do a supine head test rule. This requires the patient to lie in supine, and then the therapist flexes the patient's neck to 20 to 30 degrees so that they align the lateral canal in a horizontal plane, and then they turn the patient's head as shown in the figure 90 degrees to one side and observe for symptoms and note the nystagmus and the severity of the direction. And then once the symptoms subside, then the therapist turns it to the other side to observe for nystagmus. Here you will observe a brisk horizontal nystagmus in patients. Now there are two potential type of nystagmus that could be found out here. One is a geotrophic and the other is an apogeotropic type of nystagmus. In geotrophic type of nystagmus, there is horizontal nystagmus that beat towards the ground, and that indicates that the affected side is less intense on the healthier side, and the debris could be located in the longer arm of the semicircular canal. The apogeotropic type, it is horizontal and it beats towards the ceiling on both the sides because the debris is located close to the ampulla or is adhered to the ampulla, that is scupulolithiasis. In this case, the side opposite to the strongest nystagmus is the affected side. Now, once we detect the side, we have to conclude on our diagnosis. For that, we have to rule out what could be the potential diagnosis as well. The first one is known as a Meniere's disease. Meniere's disease is associated with vertigo, but it is also accompanied with hearing loss and tinnitus. So therefore, we can rule that out. Coming to orthostatic hypotension, in orthostatic hypotension, patient complains of getting up from bed feeling dizzy. In this, we could assess the blood pressure in lying and standing, and if the systolic blood pressure decreases to less than 20 mm per Hg, we can confirm it as orthostatic hypotension. Hence, in the beginning of examination, I asked you all to measure BP. Vestibular neuritis is a viral infection of the vestibular nerve which presents with vertigo. Here, the patient will have imbalance and disequilibrium, but in a BPPV patient, there will be no imbalance. Therefore, we assess the balance and coordination in a patient suspected to have BPPV. Traumatic brain injury, they have a case of vertigo may be present due to inner ear trauma. Occlusion of anterior inferior cerebellar artery will have other symptoms such as lower extremity involvement. Coming to treatment methods, the treatment now that we understood the mechanism of BPPV, there is absolutely no point of pharmacological intervention because it is only asymptomatic treatment. It does not resolve the problem once and for all. But the most commonly used drug is the anticholinergic, as it stimulates it inhibits the muscarinic receptors that causes the that decreases the inhibition of the vestibular velocity of the nystagmus, and it increases motion tolerance and helps. It provides a symptomatic relief to patients. Coming to what we do, these are known as repositioning maneuvers. The first position is known as a Canal repositioning maneuver. So in this maneuver, it requires the patient, just as in Hall-Pikes Dix maneuver, to have a couch without having a wall against it. So it requires the patient to be in long sitting. The therapist turns the patient's neck 45 degrees, extend the neck to another 30 degrees, and in one swift motion bring the patient down. Holds this position until the symptoms have decreased. Once the symptoms have decreased, the therapist swiftly turns the neck to the unaffected side and holds this position for another 30 seconds. Once the 30 seconds are ended, the therapist tells the patient to turn to the side that is unaffected, that is to turn towards the side where the head is facing. Simultaneously, the therapist turns the neck further downwards and holds this position again for another 30 to 40 seconds. Once the 30 to 40 seconds are done, the therapist makes the patient sit up. This is known as the canalit or the this is usually done for the posterior semicircular canal BPPV. The next one is the liberatory or the Simon's maneuver. In liberatory or Simon's maneuver, it requires the patient to be sitting in the middle of the couch, turned to the unaffected side. Okay, and then in one swift motion, we bring the patient into side lying in such a way that the nose is pointing towards the ceiling. Hold this position until the symptoms have subsided or until 30 seconds. Once 30 seconds are done or once the symptoms have subsided, make the patient sit up. Hold this position again with the neck being turned towards the unaffected side. Hold for another 30 seconds and bring the patient back to side lying with the nose facing downwards. Hold this position again for 30 seconds and then make the patient sit up. This is the end of liberatory or Simon's maneuver. These are the two methods which are commonly used for posterior semicircular canal BPPV. Now moving on to lateral semicircular canal BPPV. The first treatment method is known as the Lempart or the 360-degree barbecue roll maneuver. This 360-degree or this maneuver requires the patient to lie in supine lying with the head turned towards the affected side. We maintain this position until the symptoms have subsided or for 30 seconds. Once the symptoms have subsided, we turn the patient's head to the unaffected side and hold for another 30 seconds. After 30 seconds, we ask the patient to roll prone or on their stomach, and we also rotate the head prone, causing the patient to be nose down towards the couch. This causes the patient, most authors recommend to end the position here because according to them, anatomically speaking, the debris have returned towards anatomical position. But originally, the patient is asked to roll over to supine from prone and continue to look towards the affected side, hold this position for 50 to 30 degrees and then sit up. This, due to this complete 360-degree roll, it gets its name known as barbecue roll maneuver. Coming to Guffoni's maneuver. Now, Guffoni's maneuver has two variations based on the nystagmus that is observed. If it is a geotrophic type of nystagmus, we have the patient sitting in the middle of the couch like this, and we take the patient to the unaffected side without change in position of the head. So they lie down like this and we wait until the symptoms have subsided. Once the symptoms have subsided, we turn the patient's head facing nose down, either nose down of 30 to 40 degrees of neck rotation to the to this side, and then hold this position for another 15 to 30 seconds and then make the patient sit up. Now, if the patient has a apogeotrophic type of nystagmus, the patient isn't sitting, and then we take the patient into side lying towards the affected side. We hold this position until the symptoms have subsided. Once the symptoms have subsided, we rotate the patient's head 30 to 40 degrees towards the affected side. Hold this position for another 30 to 40 seconds and then make the patient sit up. This is the Guffoni's maneuver. Now coming to anterior semicircular canal BPPV. Now in anterior semicircular canal, BPPV is very rare and hence the treatment methods are not established, but these two methods are still in terms of being recommended so far. The Kim Yakovini's method requires the patient to be sitting up straight. Consider this as my patient and he's sitting up straight. And in one swift motion, we bring the patient downwards in such a way that the head is extended 30 degrees. Now maintaining the head for 30 degrees, we maintain this position until the symptoms have subsided or for 30 to 40 seconds. Once the symptoms have subsided, we bring the patient's neck into forward flexion and hold this position for another 30 seconds and then make the patient sit up. The next the next maneuver is known as the deep head hanging maneuver. This requires the patient to be sitting and turn their head towards the affected side. In one swift motion, we bring the patient into supine along with the head extended and maintain this position until the symptoms have subsided. Then, once the symptoms have subsided, we flex the necks in such a way that they are in line with the rest of the body while maintaining the neck turned to the affected side. Hold this position for another 30 to 40 seconds and then make the patient sit up with the neck flexed to 30 degrees. Hold this position for another 30 seconds and then relax. The drawback of these maneuver, it includes that 6 to 7% of the individuals experience canal conversion. That is, the otoconia goes from one canal to the other canal. Please note that all these maneuvers require no restriction post maneuver. Single treatment is sufficient. Multiple treatment is given for those who have persistent nystagmus. Now coming to exercise. The first exercise is known as Brandt-Dartov exercise, where when this exercise is prescribed when the side is not clear for a posterior semicircular canal BPPV and when all the maneuvers have failed over a period of time. So it requires a patient, as shown in the figure, to be sitting in the middle of the couch and go into side lying in such a way that his nose is pointing towards the ceiling like this. And once the symptoms have subsided, he sits back straight and does the same thing on the unaffected side, on the other side. This should be done. This should be repeated at least 5 times thrice in a day for 2 weeks. The next exercise is known as the home applies maneuver. This requires a patient to be the maneuver that was done actively by us. It requires a patient to do it actively by themselves. So this is repeated every night. So that post vertigo the patient could have a good sleep and it could resolve their further fear when compared to doing it in a daytime. So each position as shown in the figure has to be maintained for 30 seconds except for the last position, that is long sitting, is maintained for 1 minute. Coming to the Foster's or half somersault maneuver, each position as shown in the figure requires a lot of flexibility and strength, and observing that most patients develop BPPV over 50 who have low strength and flexibility is not really advisable, as this requires the patient to be kneeling on the floor and attain different head position as shown in the figure. Now coming to the surgical part of it. The surgeries were commonly performed in the past for BPPV, but currently due to the discovery of repositioning maneuvers, there has been a decline in it. The surgeries are performed only when the case don't respond to maneuvers as well as exercises. So the first one, known as a singular neurectomy, was commonly done in the 1970s. It involved sectioning of the posterior ampullary nerve. This ampullary nerve sent impulses from the semicircular canal to the brain, and hence by sectioning it there would be no impulses to reach the brain. for that respective canal. Coming to the posterior semicircular canal occlusion, this method effectively occludes the cupula and renders unresponsive to normal angular movement. It is done under general anesthesia through a mastoidectomy to access the posterior semicircular canal. A plug from bone dust and fibrinogen glue is used to occlude the canal. Now, post surgery in posterior semicircular canal, due to the occlusion of the inner ear, most patients did experience imbalance. So they would come back for physiotherapy to train for imbalance. This brings us to the end of the session. These are my references, and thank you.
Thank you so much, Rinita. Really wonderful session. Actually, when you talk about vertigo, you can talk for 2 days actually. Even
Yes.
for workshops, they are organizing for 8 hours or 12 hours like that. But in a nutshell, you have covered maximum information. Thank you so much. And I would like to thank Dr. Annie Thomas, Principal at HOD of St. John's College of Physiotherapy, and all other professors who are encouraging the students to present in ExRxIndia for the students, by the students web series. I thank you, Rinita. I thank ExRxIndia team members, Dr. Rupesh and Professor Duna. Thank you so much, and thank you all.